Hello friends, welcome to Srinitralay. In this another interesting video which is having a anterior capsular fibrosis, we will see how to manage the cases with anterior capsular fibrosis and the challenges we may face any day we are operating on such case. The scenario becomes more complicated if the area of fibrosis is larger and involving the rhexis margin, as in this case of mine. So I go in with the two ports. The main port is 2.6 and the side port is 23 gauge. Anterior chamber is formed with viscoelastic, and here we can note, because of the anterior capsular fibrosis, the zonules are stretched and the whole of nucleus bag complex is pulled towards one side, and the lens edge can be very well seen with a gap from where you can see the vitreous. In such scenarios, the bag may not be very much stable. That is one worry which I had in back of my mind. So we have to be careful while handling this capsular bag. Anterior chamber is formed with a slightly high density viscoelastic, and here I go in for a rhexis. I tried the rhexis with normal cysteto, but even though I tried to the maximum and applied a maximum force, the bag moved to one side, but the anterior capsule did not budge. And when I am looking at this video, I realize that how much pull I have given to the zonules, which I must not have done. So such observations of our own video becomes the surgical audit, and next time you will be careful while performing such maneuvers. And this is the reason why this complicated case is totally unedited posted here. So now I am sure my capsulorhexis needle will not work. So again I left it and form the anterior chamber and go in with a nick followed by cutting of an anterior capsule with micro scissors. Having these micro scissors and micro forceps is a must part of armamentarium for any surgeon. The good part about these capsules is, even though they are torn and the edges are not very regular, so even though irregular, these margins are usually very strong. The main port is used to insert the micro scissors inside, and more than 70% of the anterior capsular area is cut. I'm using a side port to cut that remaining part, but that was becoming difficult as it was a mature cataract and leaks can cause more trouble during phacoemulsification process. So I don't wanted to increase the size of side port, and there I had to struggle a bit to make this rhexis complete. So yet another trick, and I have to use the micro forceps to pull the anterior capsule to one side and then cut it with the micro scissors with my right hand. Once this cut is done, I felt a sigh of relief, and we can very well note how the bag is centralized now and the zonule stretch is relieved. The bag is well centered. We have a mature cataract in the bag with irregular though strong edged rhexis. I performed a hydro and go in with for Phaco. Rotation of nucleus helps in such situation, but too much rotation can cause damage, so I just tried it a bit. In such scenarios, if you have Alcon machine with torsional power is a boon, because with torsional power you can just keep eating this nucleus there itself without causing any stretch on the zonules. So my settings are torsional power 100%, longitudinal power 0, with intelligent Phaco off, and a vacuum of 400 and a flow rate of 36. That is why we can see very easily the nucleus part is coming out, and most of the nucleus will come out without much hassle. So once the half of the nucleus is out, I will take the another half. We can form the anterior chamber in between and have a better control over the stability of anterior chamber. Once the nucleus is almost getting over, I can note that the posterior capsule is also having many fibers attached to it. This type of situation is usually seen in very hard cataracts and mature cataracts. The one method which I have demonstrated earlier in my videos is a PC capsule polishing with the help of lens itself, using it as a third hand of a surgeon. Now here I am using a CTR ring to support any loose zonules because I had pulled this zonules slightly more, and these type of situations can have a decentered bag later in the future. So I am going in with my DIY self-made single-handed CTR injector system, video for which is available on the channel, and CTR is loaded into the injector, and this CTR can go in the bag very deep, close to the bag without causing any stretch on the zonules. We can implant this CTR easily with this method. This is a must watch video. If you haven't watched it, please search on the channel. You will get the video. The trailing haptic, you can go to the periphery of the bag and implant it there itself without causing any zonule stretch. Once the CTR has gone inside, we can note the folds from the posterior capsule are gone and the stretch on the zonules is relieved. Now we can go in for posterior capsular polishing and cortical wash. While performing a PC polishing, one must face the tip of irrigation aspiration probe towards up and not towards the posterior capsule to avoid any inadvertent capture of posterior capsule causing PC tear. If you capture posterior capsule and you will see a spider leg sign, don't worry, use the reflex method and your PC will be released. In such scenarios, do not pull the hand after seeing this spider leg sign as we can see here. Capturing the posterior capsule do not cause any PC tear, but pulling it after capturing do cause. Many people get scared after capturing the posterior capsule and pull their hand outside, and that causes PC tear. So if you catch the PC, just stay there, use the reflex and your PC will be released. In such scenarios, I usually prefer a 3-piece IOL which is having a very good stability in the bag and in the sulcus if needed. So here I am implanting Sensor 3-piece IOL through a Alcon 3-piece IOL injector. I have increased the port size of my main port to around 3 mm to have a better implantation of this 3-piece IOL. How to implant these IOLs, I have a separate video posted on a channel. Once the first haptic and optic is inside, the trailing haptic can be left behind in the wound and that can be dialed later on after formation of anterior capsule and see how well it is settling in the bag. I go in with my irrigation aspiration probe and perform a visco wash. We can note the prolapse of iris through main wound as the incision size was increased for implantation of a 3-piece IOL. It will settle down with hydration of wound. I hope you must have find this case interesting. Do subscribe to our YouTube channel Dr. Pankaj Lande for more such exciting videos. Thank you and good day.